So we conducted a phase 2 prospective single-arm study for response adaptive ultra-low dose radiation therapy for indolent B-cell lymphoma of the ocular adnexa. And so that can impact eyelid, conjunctiva, lacrimal glands, soft tissues of the orbit. And when patients present with indolent B-cell lymphoma in the orbit, the most common histology is malt lymphoma when it's just limited to the orbit, but you can have follicular lymphoma, unclassifiable low-grade B-cell lymphoma. Most patients and most oncologists would regard radiation therapy as the standard of care, although there is a lot of variety in how these patients are managed, and mainly that's because of concern for ocular morbidity. So historic doses of 30 to 50 gray, where gray is our unit of radiation, have been utilized. With those doses, local control has been excellent, in excess of 90%, but there has been significant ocular side effects that have been noted, including grade 3 and grade 4 ocular morbidity. So the radiation dose has been lowered to 24 gray, and 24 is considered the standard dose at this point in time. But even with those doses, there have been studies reporting, some common side effects that may be lasting, including cataract and dry eye. And so, we are interested in an approach that could potentially result in continued high levels of efficacy, but reduce side effects. So the FORT trial is a randomized non-inferiority study conducted in the UK, and they were comparing 24 gray to 4 gray, not just for the orbit, but for all sites, so follicular lymphoma and marginal zone lymphoma. And their primary endpoint, local time to progression, favored the 24 gray arm. But they did note, pretty impressive responses with 4 gray and 2 fractions, just 2 days of radiation. And so our study is kind of based on the premise that how can we identify the patients that will have a complete response to 4 gray and not give them the entire standard dose, but maybe reserve the higher dose for the incomplete responders. And so that's the premise behind the study. And that's kind of the new treatment paradigm. So all patients received 4 gray and 2 fractions to the orbit. And those at 3 months, if you had a complete response, we observed. If you had stable disease or progressive disease, we recommended another 20 gray to complete the 24 gray course. But if you had some response, but not complete response, we would follow you. And 3-month interval. So up until 1 year's time. And if you have persistent disease at 1 year, then additional 20 gray was recommended. And that's kind of the overall treatment approach. And so the study enrolled 51 patients. There were 50 patients that were eligible. And we had, at a median follow-up of just over 3 years, 90% or 45 patients out of the 50 had a complete response to response adaptive therapy. And that included 44 patients that only needed 4 gray and 1 patient that had required additional 20 gray to experience a complete response. Overall, we had 6 patients that were eligible for the additional 20 gray. Only 2 of them received it. And the other patients that didn't receive it elected to be observed or receive systemic therapy out of patient or physician preference. And so for the entire cohort, local control rate was 89%. Overall survival was 98%. And among the patients that had a complete response to therapy, we didn't note any local relapses. And so we're very encouraged. Prospectively, we evaluated toxicity. 6% of patients experienced grade 1 toxicity, which was dry eye. And we didn't have any grade 2 or higher toxicities that we noted. And we did exploratory analysis of patients with limited stage malt lymphoma of the orbit, and there are 22 patients in that planned exploratory cohort. And amongst those patients, we've found excellent local control, geolocal control of 91%, and the distant freedom from distant relapse rate at 2 years was 95%. We did have 3 distant relapses in the contralateral orbit, and then for 2 patients in the mediastinum for 1 patient. So those numbers are on par with historic retrospective series of distant relapse rates. And so the biggest concern with giving patients a substandard dose of radiation and a potentially curable patient population is that we're going to get higher relapse rates, especially potentially relapse rates outside of the orbit while you're awaiting a response. And so I think our study endorses that this approach, we do need longer follow-up to assure, durable local control. But we're seeing numbers that kind of coincide and align with with more modern and historic retrospective series. So this is our standard approach now at MD Anderson for all of our stage 1 limited stage malt lymphoma patients. overall, we're just really excited about the study. We, in addition to the prospective cohort, we had a 55 patient retrospective cohort that were treated at MD Anderson with the same approach, but off study. And we observed great rates of complete response to the response adaptive strategy in that cohort as well. 98% of patients in the 55 patient cohort had a CR to response adaptive therapy, and only 2 of them required 20 gray to experience that CR. And so, with this combined cohort now of over 105 patients treated this way, this has become our new standard, especially for mild lymphoma patients at MD Anderson. We're really excited that this work is being adopted at other centers. And so our colleagues at our colleagues at Sloan Kettering, so Dr. Yahalom and Brandon Ember, are starting a randomized study where they're using our response adaptive strategy compared to upfront 24 gray for patients with stage 1 follicular lymphoma and stage 1 and stage 2 marginal zone and follicular lymphoma. So excited about what that randomized trial can do for our field. So we're just excited about what this work can mean for our patients. A potential treatment that has, decreased toxicity, is more convenient for patients to receive treatment in 2 days, potential decreased financial costs for our patients. We're excited about that. I just want to acknowledge all of our medical oncologists, my colleagues in radiation oncology here at MD Anderson, and my co-PI, Dr. Bita Ismaili. She's an ophthalmologist that's co-PI in the study, as all of our patients that participated.